Hello, my name is Zahar Kanyuka, and I'm a third year medical student at the University of Saskatchewan. Today, for the CAR RFS MSN, I'm excited to interview Dr. Sinclair. I first met Dr. Sinclair last year at CARE, which is the Canadian Interventional Radiology Conference, and then I had the pleasure of shadowing her in sunny Saskatoon later on the same summer. So now I'm absolutely thrilled to learn more about her and about her career and leadership by interviewing her for this project. Now, without further ado, let's hear from Dr. Sinclair about uh, a little bit about her.
Thank you very much. Yes, so my name is Nicolette Sinclair. I am a interventional radiologist in Saskatoon, Saskatchewan. I grew up in a smaller community in northern Saskatchewan called Prince Albert, and then did my undergrad training in South Carolina, medical school in Vancouver at UBC, came back to Saskatoon for radiology residency, and then off to Toronto to UHN for my interventional radiology fellowship. And I finished that in 2015, in June 2015. And then I started in Saskatoon, July 2nd, 2015. And yeah, so I've been a practicing radiologist. I'm a partner with Associated Radiologists. I also am very involved in leadership. I am the area department lead for medical imaging for Saskatoon, along with one of my neuroradiology colleagues. I'm on the executive for my radiology group. I'm also involved with CARE as the co-editor of the CARE Express. I do all sorts of other small projects, quality improvement, leadership things along the way.
Very exciting. Sounds like a very thrilling, very rewarding career. So, if we could learn a little bit about how it started, why did you choose radiology in the first place?
So I think I was a little bit late to radiology, or I felt that way. I felt like when I got into medical school, a lot of the students already had, in their mind exactly what they were going to go for. And certainly there were many radiology keeners, the radiology keeners in the class who declared themselves in first year. I was unsure at that time. Actually, I remember I was interested in obstetrics and gynecology in first year, and that quickly went away. But, I kind of was, de-differentiated. I didn't have a specific, dedication over the first 2 years of medical school. And it really wasn't until third year when we got into the hospital and started rotating through our rotations that I decided that radiology was for me. And really, I love the diagnostic aspect of it, obviously. And it always just seemed that all of the sickest, kind of most interesting patients always found their way to medical imaging for diagnosis or some sort of intervention or treatment. And, I just got the feeling that the radiologists were pretty integral in figuring out what was happening with the patient and leading the treatment. So in third year, I decided I was really interested in radiology. I quickly set up some electives because I was a little bit late. I didn't have any research in radiology on my CARMS application. My research was in obstetrics because I did it between first and second year. And so I quickly set up some electives throughout the country. I went to St. John's, Newfoundland. And again, I was based out of Vancouver. So St. John's, Saskatoon, Calgary, Vancouver. And I also set up lots of electives in, I did ortho trauma for a month. I did vascular surgery. I did pathology as well, which I loved my pathology elective. So I did lots of electives that were pretty heavy on imaging as well. And that solidified my desire to do radiology for sure. And I will say during my vascular surgery elective in Vancouver, a vascular surgeon, and I forget his name and I feel bad about that, taught me how to do chest port insertions and let me do a bunch of them with him. And I thought that was the coolest thing. And so that was my first, I would say, introduction to interventional radiology. And he even said, if you're interested in radiology, there are lots of interventional radiologists who do this. So that kind of got my interest into interventional radiology.
Doing those procedures as a medical student sounds like an absolute dream to me.
Well, it's funny because now, again, obviously there's bread and butter procedures, but yeah, it's less exciting now. But as a medical student, it was just, yeah, it was a great day. And, I was very proud of myself, and he gave me a lot of confidence. So that was really nice.
So you were quite interested in obstetrics and gynecology in the first place. What pulled you over to radiology? What were the biggest things that deterred you from the other option?
Well, I did do we all have to do our obs-gyn rotation, and that was one of my first rotations. And though it is thrilling, babies tend to come all throughout the night. And it ended up not being something that I was super passionate about. I certainly enjoyed that rotation. I enjoyed many of my rotations. I think I actually would have been pretty happy in lots of different specialties of medicine. Similar that I feel I would have been pretty happy with lots of different subspecialties within radiology. But it didn't really click with me. And yeah, I was more interested in ultrasounds than delivering of the babies.
So, given that it sounds like you found quite a bit of radiology and quite a bit of medicine in general interesting, what besides the fun experience of putting in lines on your vascular surgery rotation drew you to interventional radiology in particular?
Well, once I got into radiology residency, I wasn't dead set on interventional radiology. I still didn't really understand how you subspecialized in fellowships and that type of thing. I was a bit naive to that. And again, in PGY2, we actually have to do, or we used to anyway at U of S, have to do interventional radiology rotations in PGY2, which is a little bit early. But I did a interventional radiology rotation at St. Paul's Hospital, which is where I work now. And I met an amazing interventional radiologist named Dr. Bruce Burscheid, and he became a mentor to me, again, from a pretty early on, and really encouraged me and took me under his wing. He'd been practicing for 30 years and taught me, lots of stuff. Again, one of the nice things about being a resident in a smaller center without fellows is, as a resident, we were doing, angiograms and like tunneled line insertions and like lots of procedures, like lots of solid organ biopsies and, with a lot of supervision. But I think we got more exposure to those types of things than if you were at a larger residency program with lots of fellows, because obviously the fellows were doing that. And I know when I was in Toronto, I was maybe by the second half of the year, I let the residents do a PICC line, but otherwise I was, elbowing them out of the way to get experience. But yeah, we had no fellows to compete with. So if you showed a keen interest at all, or, any kind of competence with holding a needle, they were really willing to teach. And so I think I got pretty lucky in where I was a resident and my exposure pretty early on to interventional radiology. But the thing is too, you don't have to be an interventional radiologist to do a lot of procedures in your practice. There are lots of other subspecialties of radiology that do a ton of procedures. And it depends on the practice that you're in, the size of the center that you're in, what the abdominal imaging fellows or fellowship trained people do, what the chest fellowship trained people do. Obviously, breast is a huge amount of intervention. MSK is a large amount of intervention. So you don't have to do interventional radiology to do procedures, for sure.
It sounds like every field can procedurally be quite exciting, on top of the fascination of the imaging aspect of it.
Yeah, absolutely.
In present day, what does a typical day at work look like for you?
So I would say I'm about 50-50, IR as far as in the angio suite versus on the floor. So if I'm in the angio suite, then it's bread and butter, typical stuff. We do a lot of peripheral vascular intervention at my hospital, lots of angioplasty stenting. We do atherectomy now. We do, I would say advanced arterial intervention. So that's a lot of the day. it's also a dialysis center, so we do a lot of dialysis intervention, fistula intervention, tunneled line insertion. We also do, that's more bread and butter, but we also get, various types of embolizations. We don't have as big of a interventional oncology practice as other sites. We're not associated with the cancer center, but we still do a lot. We do a little bit of TACE. We do more of the thermal ablation, renal or liver thermal ablation, but that actually is done when we're on the floor. So when we're on the floor, we do a fair amount of diagnostic radiology. That day is maybe 50% diagnostic radiology, which is nice to keep your skills up in that, because I do think you need to be a good diagnostic radiologist will be good interventional radiologists, being able to interpret the images. So on those days, we do diagnostic radiology and then all of the CT and ultrasound guided procedures. So all level of drainage, biopsy, and then that's where we do our ablations, whether it's renal. We do primarily renal or hepatic ablations, and we do either radio frequency, microwave, or we have NanoKnife as well in Saskatoon.
Very cool, very dynamic practice by the sounds of it.
Yeah. Oh, and I do PD catheters. We have 3 interventional radiologists, and I am one I do peritoneal dialysis catheter insertion, which is a relatively straightforward procedure, but I get a lot of, it's very rewarding because I do enjoy being able to help patients do home-based dialysis as opposed to in-center dialysis. So it's something that's become a bit specific to my practice anyway.
That's very life-changing. And I think one of the big draws of the more patient interaction subspecialties in radiology is keeping that connection to the patients and getting the rewarding feeling of seeing what you're doing day to day. Out of all these procedures, which ones do you do the most often on a day-to-day basis?
Most often in angio, it will be like peripheral, like a leg intervention, like a chronic total occlusion of an SFA, or like below knee chronic occlusion, angioplasty, stenting, that as well as dialysis. So like tunneled line insertions or fistula intervention. And then, as far as biopsies, we do a fair number of lung biopsies. We also have a big thoracic surgery presence, so lung biopsies, and then just abscess drainages, all sorts of abscess drainages, CT guided, ultrasound guided. Yeah.
And on the opposite end of the spectrum, what's the most favorite or memorable procedure?
Favorite? My favorite procedure, I like acute embolizations, like GI bleed, embolizations, or embolization for trauma. We are not a trauma center specifically, but it's quite impressive how much trauma just kind of walks in off of the street or gets dropped off at the front. I like GI bleed interventions. I think they can be technically pretty challenging. You need to make the decision on what kind of embolic are you going to use. Are you going to use coils? Are you going to use a liquid embolic? And then the patient tends to, if you do it right, tends to get better right in front of your eyes, and you can literally hear the beeping of the blood pressure machine, changing, and like the tone changing, and it's pretty satisfying to see a pretty immediate result in your procedure, because a lot of the other interventions that we perform, you don't have like an immediate feedback of this patient's getting better right away. So I do like kind of trauma or acute embolizations for that reason. Of course, those happen in the middle of the night often too, or on the weekends, or just in opportune times. But again, that's part of being an interventional radiologist. Our call is very different from general radiologist. It's, can't be done completely remotely. So we're in the hospital a lot, but I do like that.
It sounds very thrilling.
It is
well worth getting out of bed at 3 a.m.
Yeah.
Overall, what's the most rewarding thing that you do?
I mean, it's super rewarding to treat patients and to see, good outcomes in patients. whether it's immediate or, you know, seeing follow-ups of your ablations, we seeing that, you know, okay, we cured that renal cell carcinoma, or we're improving, you know. Oh, you know, I forgot to mention, I do a lot of vascular malformation intervention. So in those patients, I have like chronic patients that I see repeatedly. So it's nice to have some patients where, you know, you maybe treat them every couple of months, and then after a couple of treatments, they say, oh my gosh, this is so much better, and the pain is almost gone and I feel better. So obviously getting that feedback is quite rewarding. I would also say I find it super rewarding to help my colleagues. So radiologists and interventional radiologists spend a lot of time talking with referring physicians. So whether it's the surgeons or the internists or Emerge or whomever, and, you know, often when they're coming to talk to you, they're asking for your help because they have a problem and they are hoping that you can maybe help them. So I find it super rewarding to help out my colleagues and help their patients who become my patients. But, you know, oftentimes, particularly acutely ill patients don't realize in the end who it was that did the procedure or what. So they don't know it was you, and that's fine. It's, you know, but the referring physician knows how much you helped. So I really enjoyed building those relationships. You know, over the 7 or 8 years that I've been here, it's rare that there's a physician who works at my hospital that I don't have their number or they don't have my number. So it's nice. I've made a lot of friends, and, you know, it's always interesting because, you know, they always say, oh, I have a favor. Can I ask you a favor? I need a favor. And I'm like, you know, this is my job. It's not a favor. Like, this is what I do. So it's nice that, I mean, they think I'm doing them a favor, but I'm like, no, this is just like what I do. Yeah, so that's rewarding too.
To take a step in a different direction, in the beginning of our interview, you mentioned a lot of other leadership involvement, such as your involvement in care and involvement in your practice and involvement in quality improvement projects. Can you tell us more about those?
Yeah, I mean, I'm trying to get kind of specifics. Well, with care, I have been involved the last year or two with being the co-editor of the Care Express, which is a newsletter that comes out. So it's not research, it's you know, kind of informative pieces or highlighting different interventional radiologists, different procedures, kind of what's going on around the country in interventional radiology. So that has been a lot of fun. It, you know, has been a fair amount of work, but that's something that I have been doing with my co-fellow who practices in Toronto. So it's also a nice way for us to kind of stay connected. So that's been really good. You know, my leadership in Saskatoon and in medical imaging really started, you know, kind of ground floor, you know, frontline level. I never had any formal leadership training, certainly, but I've always been you know what? I've always liked to know what is going on and what is coming in the future. So when opportunities arose to, whether it's be on, you know, committees or some sort of leadership position, I generally volunteer for those. And then once you volunteer once and you show you know, baseline competence, or they see that you actually show up to the meetings, you keep getting asked to do things to the point where at some point you need to say no to things and really select the areas that you enjoy. So I've kind of gone down the leadership, like the medical imaging leadership route in Saskatoon. You know, there's lots. I would encourage anyone getting into medicine, radiology, anything that, you know, the clinical work is super important, obviously, and I love the clinical work, and we all need to do that. But, you know, whether it's teaching or research or quality improvement or leadership or whatever it is, there are other kind of facets to a career that can be quite rewarding. And not only that, it can be nice to break up some of the clinical work because that can be quite draining. Leadership can be draining too, but it's nice to be able to change between the two. And so, you know, sometimes I feel like my when I do my leadership work, that is a nice break from, being in the hospital and being constantly asked, can you help me with this? Can you help me with that? Come here, do that, interruptions, that, which I like, that fast pace. And then I find that my clinical work is a nice change from some of the leadership stuff, which is stressful in a different way. Some of the quality improvement work that I've done quite a lot with PD catheter insertion, because when I started, all of our PD catheters were inserted surgically, and there was a very low patency rate. And so we kind of developed this multidisciplinary team to try to kind of look at, okay, well, what's going on with our patencies? Like, what kind of changes or improvements can we make? I did not train in peritoneal dialysis catheter insertion during my fellowship or residency. Obviously, nobody was doing them. So I had to go to McMaster for a course and learned how to do it there. And it was an excellent course. And so came back, started a program, but had a huge team of people around me, including, primarily from the dialysis unit, who really helped me. And so that has been really satisfying. And our patency rates have really skyrocketed. So that's been nice to see over I guess it's 2016 I started, over the 6 to 7 years that I've been doing PD catheters. Other little things, I really do like standardizing. Or at least I like the idea, and I like working towards standardizing just various things around medical imaging. And so we have been recently working on standardizing kind of approach to anticoagulation for the whole province of Saskatchewan, not just Saskatoon, not just my hospital, but trying to standardize it throughout the entire province, because patients are obviously moved around quite a lot. We also have the benefit of having a single unified health authority, as you know, in Saskatchewan, which lends itself to lots of opportunities for standardization throughout the province, not just city or site. So I enjoy that. That was a long answer.
Oh, we very much appreciate it. It's certainly exciting to see a lot of changes come about through this kind of work as well.
I will say it's slow. Like you put a lot of work into it, and it's quite frustrating, and you feel like you're going nowhere. So it is slow work. It's not like that immediate gratification as doing like a perfect, GI bleed embolization where immediately something happens and you're like, yes, I did that. That was me. It's a slow burn. But again, looking back over years, you can see a slow changes being made.
So, looking more broadly, what would you say the job market in interventional radiology is like, and where is it headed in the next 10 or so years?
The job market's good. I think for interventional radiology, certainly for just radiology in general, it's good. This is my understanding, certainly for Saskatchewan, but also for the rest of the country. There are more jobs posted now than I've ever seen throughout Canada. So I do think that it's a good time to go into radiology. I will still say I encourage all the radiology residents to do a fellowship. It doesn't have to be interventional radiology, but I do encourage people to get some sort of extra training. It is nice to have a kind of subspecialty expertise. Radiology is expanding so quickly. And, I don't necessarily think I don't want to watch how I say this. I don't know if you can be competent in most areas of radiology after your 5-year residency. I certainly didn't feel confident enough that I would be able to practice in certain kind of niche areas. I read MR, like body MR, and then obviously vascular MR, but I read a bit of neuro, but I don't read any MSK MRI. It's just too hard to stay current with everything. Not only, the anatomy and the pathology, but also just the technology changes so quickly that even staying on top of the different MR sequences and changes there, and best practices throughout all the different subspecialties, it's really hard. So I think having a subspecialty with extra training, you definitely bring something to a group, you add value to the system in your expertise in that. So I would encourage everybody to do a fellowship. There's still a lot of, general radiology to be done. So we all do our fair share of general radiology, but it's just nice to have a large cohort of subspecialists to ask second opinions of, or to rely on for some of the more complex patients. Yeah.
And for medical students such as myself who are seeing CARMs approaching fast, and we're measuring ourselves up against different specialists and specialties, different fields in medicine, what are some good personality traits for a radiologist?
I think there are many. I'm going to look at my list because I wrote some down. There's lots. I don't think you have to be one specific way or have one specific personality. I think the more variety that we have in radiology, the better. So what did I have written down here? So I think all radiologists need to be relatively focused because, you need to be able to focus on your work without getting too distracted. Curious, you need to constantly be kind of, willingness to learn. You want to keep learning. Again, like radiology is changing so quickly. If you have a 30 to 40 year career, there's absolutely no way that it's going to be the same at the end as when it started. Now that's medicine in general, but I do feel as though radiology is moving almost faster than a lot of other specialties, just because of how dependent on technology we are. And certainly interventional radiology with all the different devices coming out constantly. So I think you need to be very curious and willing to learn. Obviously attention to detail, work well under pressure. I think you can be, whether it's introverted or extroverted, I don't think you have to be one or the other. I think it takes all types. You can be both or either. Empathetic. I think to a certain degree, you need to be willing to collaborate with others. If the idea that a radiologist just sits in a room, doesn't talk to anybody, doesn't interact with patients is incorrect. And that's not just interventional radiology. Now, I guess I can take that back. There are jobs in the country that would be completely outpatient clinic based, and you would be sitting there just reading X-ray and ultrasound, or perhaps if you're in an area that has outpatient clinic-based MRI and CT, then you'd be doing that. But I think that is the exception. The vast majority of radiologists spend time, whether it's interacting with patients or interacting with other physicians. So you have to be able to talk to people. I would say those are the main ones.
Speaking of this idea of a radiologist sitting in their dark reading room and not talking to any patients or any other clinicians, what are some other common myths about radiologists that you would like to disprove?
I think that's the main one. I think that we're, overall grumpy and don't want to help, though I have met some grumpy radiologists, certainly. But I think, what we do want to help. We want to help the referring physician. We want to help the patient. I think the myth, mainly that we don't want to talk to anybody. I think that's it.
And finally, for those of us who are now even more sold on radiology, what are some pieces of advice that you would give to medical trainees, especially those who are interested in pursuing a career in radiology?
Yeah, so if you're early on, first of all, don't feel stressed or bad if you are a little bit late deciding on radiology. You can decide in third year, and I still think you will be, have a good chance of being successful. If you know early on, within first or second year of medical school, and are able to get involved in just, you don't have to do major research, in my opinion, depending on what site you're looking for. Maybe Toronto and Vancouver, it's different. Maybe you need to do tons of research. But for the most part, from the applicants that I see, if you can get whether it's a quality improvement kind of project or a dean's or like a summer project, with whether it's a little publication or a poster, I think that's important to have on a CARMS application. But it doesn't need to be, groundbreaking research. definitely in first and second year, shadow if you're able to. I didn't shadow anybody. I didn't shadow a single person in first or second year. I was a very average medical student. I just studied. I didn't do much else. I wasn't involved in leadership in medical school. I'm trying to think back of what I did. I didn't do much. I did one project between first and second year. But if you can shadow, I think that's a good way to get exposed to what different specialties do. By the time you get into your rotations, I think there's very little exposure to actual radiology, certainly in first and second year, and even in your rotations, unless you seek it out in an elective. But even when you are on your different rotations, whether it's surgery or internal medicine or pediatrics, kind of like I said, the vast majority of patients will make their way down to medical imaging. So I would encourage you, if you've got an interesting case or sort of like a mystery case on your list or on your team, ask if you can, and they're going down to CT or they're going down to MRI or they're going down for an ultrasound, just ask your senior, just say, hey, I'm really interested in this case. Do you think I could follow this patient down to medical imaging and just see what they do? And just go in there, and ask, I'll ask the ultrasonographer to say, hey, do you mind if I watch you do this abdominal ultrasound on the medical student? Or just ask the CT tech, hey, can I stand in the console and just watch this CT? And certainly for if they're going down for any procedures, whether they're going down for a chest tube or a PICC line or a GI bleed embolization, follow them down. It's also a good way to kind of see the patient experience as they move through the hospital and through the system, and see what they kind of have to go through. And then you can see sort of, okay, well, what happens in medical imaging on a day-to-day basis with these different types of patients that are going down. I think that's a good way to get an exposure and get an idea of like what is happening. And then, you might meet some people along the way. Certainly do some electives. And then again, in booking your electives, if you're getting serious about radiology, then think of some specialties that rely heavily on medical imaging. So, and so many of them do, but again, vascular surgery was really great. Orthopedics is great. Any surgery is great. There's a lot of imaging there. I did a radiation oncology rotation, which was really great as well. Interesting to see how they plan the radiation with the imaging. So that is my advice, I would say.
Thank you very much. It's been really, really wonderful hearing from you.
Yeah, it's been fun.
Really appreciate this, and I hope that other medical students are just as excited about radiology and interventional radiology as you and I are.
Yes, exactly. It's a great field. Yeah.